Hi friends, myself Dr. Sandeep, physician from Jayanagar General Hospital. Today I am going to speak about basics of ECG and waveforms. So this is a slide showing conduction system of the heart. See, the cardiac potential originates from the SA node, then it conducts to AV node through internodal pathways, then to bundle of A's, then to common bundle, then to left bundle branch block and right bundle branch, then through Purkinje system, and finally ventricular muscles get depolarized. So this is the order: SA node followed by atrial muscle, followed by AV node, common bundle, bundle branches, Purkinje fibers, and ventricular muscles. So this is the order of the waveforms. Initially, there is a P wave due to atrial depolarization, then followed by the QRS, it is due to ventricular depolarization, and followed by T wave, it is due to ventricular repolarization. SA node is called as the pacemaker of the heart as it discharges with a rapid rate so that the depolarization spreads from it to other regions before others discharge spontaneously. So it is a predominant depolarizing structure in the heart. So it is called as a pacemaker of the heart. There are three bundle of atrial fibers that contain the Purkinje type of fibers which connect SA node to AV node through three tracts, that is through anterior tract, middle tract known as tract of Encke-Bach, and posterior tract is called as tract of Thorel. And there is a branch of anterior internodal tracts called as Bachmann bundle which connects the right and left atria. So this is a table showing the conduction speeds of cardiac tissue. The maximum conduction speed at Purkinje system, whereas the least conduction system speed at the SA node and AV node. So the maximal, most of the Brady arrhythmias occurs due to AV nodal delay as the conduction rate is least in AV node. So what is electrocardiography? Electrocardiography is a measure of electrical activity of the heart. It is a summation of all cardiac potential in real time. That means there are some potential which travels from in a downward and leftward direction, such as SA node to AV node, or AV node to bundle branch block, or bundle branch block to Purkinje system. But there are some potentials which travels in a reverse direction, that is from the ventricular apex to the base. But the mean axis is downward and leftward. So the mean cardiac axis is 55 degree. So it will be explained in the further chapters. And what is the concept of Einthoven triangle? See, we cannot directly place an electrode practically inside the heart to measure the electrical activity of the heart. So what does Einthoven triangle says is the heart lies in the center of the right arm, and left leg. So the electrical activity is indirectly determined by the electrical activity of the heart is indirectly determined by the electrical activity of the left arm, right arm, and left leg. So this is a standard lead to ECG. So this is the standardization also you should know. That is a one small box. This is the one small box. Okay, the one small box is 0.04 seconds in duration and zero point 0.1 millivolt in amplitude, that is in height. So, or else the one large box it is about zero point 0.2 seconds or in duration, or zero point 0.5 millivolt in amplitude. So that is width into height. So these are the waves you see normally. So the waveforms are P, QRS, and T, and sometimes U wave. So a P wave occurs due to an atrial depolarization, whereas a QRS complex occurs due to ventricular depolarization, and T wave occurs due to the ventricular repolarization. You cannot see an atrial repolarization in an ECG because it is submerged in the QRS complex. As QRS complex is a predominant electrical activity, you cannot see an ECG waveform of an atrial repolarization. So next coming to the QRS complex, the Q wave is the initial negative wave because it is a septal wave and the direction of the septal wave is from the left to right, which is against the direction of the mean axis of the art. So it is a negative vector. So you see a Q wave. Then coming to the intervals, there are two intervals which you need to, that is PR interval as well as QT interval. The PR interval is the time taken for a cardiac impulse to travel from atria to ventricle, that is measured from the start of the P wave to the start of the R wave. Whereas the QT interval, it indicates the electrical ventricular activity, that is, but QT is measured from the start of the Q wave to the end of the T wave. So this you need to remember, which is very important. QT interval is from start to end, PR interval is from start to start. So then there are segments, isoelectric segments, that is the PR segment, which is from the end of the P to the to the R, whereas the ST segment from the end of the S to the T, onset of the T wave. So this is the same slide. So now coming to the P wave. So P wave is best assessed in lead 2 and V1. What is a normal P wave? The normal P wave is upright in lead 1 and lead 2, whereas it is biphasic in V1, and it is less than 0.25 millivolt amplitude, that is less than 2.5 squares in height, or as well as less than 0.12 seconds in duration, that is less than 3 small squares in width, with a mean P axis of 40 to 60 degree. So what happens in lead 1? In lead 1, the first half or the ascending limb is represented by the right atrium, whereas the terminal or the descending limb is represented by the left atrium, whereas the middle part of the P wave is represented by both right as well as the left atrium. Whenever there is a right atrial enlargement, you see a tall P wave, whereas so it is called as P pulmonale. Whenever there is a left atrial enlargement, there is, so the P wave widens, that is increase in the duration occurs. So that is called as P mitrale. In V1, the first positive wave is by RA and the terminal negative wave is by LA. When there is a left atrial enlargement, the terminal negative wave, which increases in the duration as well as in the depth, that is, there will be increase in the duration as well as the amplitude. So the Morris index is the product of the amplitude into duration, that is depth in mm into duration in seconds. More than 0.03 indicates left atrial enlargement. So next thing what you need to observe in the P wave is amplitude of the P wave. Normally it is less than 0.25 millivolt in amplitude, that is less than 2.5 small squares. If it is a tall P wave indicates right atrial enlargement. When there is a duration, that is in a broad P wave indicates a left atrial enlargement. So whenever there is absent P wave, so the differential diagnosis depends upon the assessment of the heart rate. Although the most common cause of absent P wave is tachycardia is atrial fibrillation, but there are some other causes. Whenever there is a bradycardia, so there are the four possible probabilities. One is sinus arrest, there is a complete lack of P waves. Or a second degree sinusoatrial block, similar to the second degree AV block, there will be intermittent missing of both P and QRS complexes. When there is a complete dissociation between the P and QRS complexes, it is called as complete sinoatrial block. And there is one more entity called as junctional escape rhythm. Here there will be bradycardia with QRS complexes will be there, but P waves will not be there. So these are the four differential diagnoses for the absent P wave with bradycardia. But whenever there is an absent P wave with tachycardia, you need to observe the morphology of P waves. When there are fibrillatory, when you see some fibrillatory P waves, but there are no discrete P waves and heart rate is more than 150 to 250, more than 200 approximately, then you need to think of atrial fibrillation. When there is a sawtooth P waves, then it is called as flutter waves. Then the possible diagnosis is atrial flutter. Sometimes P waves are hidden in inferior leads, or they might follow the QRS complex. They might be submerged with the QRS complex, or sometimes they might be inverted. So you see in AV nodal reentry tachycardias. Next, coming to morphology of P waves. So where you will get a notched P waves. A notched P wave means, see, whenever there is a wide P wave, there will be two notches. The first notch is is represented by right atrium, and the second notch will be left atrium. And the duration of the notch, that is between the two peaks, is more than 40 milliseconds. It indicates left atrial enlargement. It is also called as camel arm. Next is where you will say negative P wave in V1 and V2. A negative P wave and V1 and V2 is seen in COPD because due to the downward displacement of the heart due to lower diaphragm as a result of hyperinflation due to emphysema. Okay. So when you see a bifid P wave with the taller first component, the first component is represented by a right atrium. A taller first component indicates a right atrial enlargement, whereas a bifid P wave indicates a left atrial enlargement. So bifid P wave with taller P wave implies it is a biatrial enlargement. The most common cause is mitral stenosis with pulmonary hypertension. It is also known as P tricuspidale. Next is where you say inverted P waves, you can see inverted P waves in inferior leads 2, 3 AVF, whereas a positive P waves, normally P wave is inverted in V1, but here it will be positive due to retrograde activation in AV junctional tachycardia and atrial ectopics. But how to differentiate between AV junctional tachycardia and atrial ectopics is, in atrial ectopics, the PR interval is normal, whereas AV junctional tachycardia, the PR interval is shortened, and there will be associated tachycardia, that is heart rate more than 100. So sometimes you will see a dome and dart appearance of P wave in left atrial ectopics. So similar to the axis we measure in QRS, we can measure in the P wave also. Normally it is 40 to 60 degree. Less than 40 degree is called as left axis deviation. It is seen in left atrial enlargement, left atrial ectopics. But you can see in congenital heart disease when there is a right atrial enlargement also. Especially in ostium primum ASD, there will be right atrial enlargement, but there will be a left axis deviation. Whereas more than 70 degrees is seen in right eye is called as right axis deviation. It is seen in right atrial enlargement. So this is a slide showing the normal P wave. This is the normal P wave. The first part is represented by the right atrium. The later part is represented by the left atrium. But in between these two lines, the middle part is represented by the both right and left atrium. See, here you see a taller P wave that is more than 2.5 mm. It indicates right atrial enlargement. A wide P wave more than 0.11 seconds, and the duration of the notch more than 0.04 seconds indicates left atrial enlargement. Whenever there is a left atrial enlargement with the right atrial enlargement, the initial first part of the notch becomes tall like this, and second part will be smaller. This is called as P tricuspidale. So this is a ECG showing. See, you can see here P wave is inverted in lead 2, whereas inverted in lead 3, and here it was inverted in AVF also. Inverted P waves indicates retrograde electrical activation, most probably due to AV junctional rhythm. This is a dome and dart. This is called as a dome, and this is called as a dart appearance seen in atrial ectopics. So similarly, Morris index, there is one more index called as Marcus index. Here you measure the ratio, the duration of P wave by the PR segment. Less than 1 indicates right atrial enlargement, more than 1.6 indicates left atrial enlargement. So this is the graph showing this is a normal P wave in lead 2 is like this, and in V1 it is biphasic, initial positive followed by the later negative due to a left indicator represented by left atrium. When there is a right So, in a right atrial enlargement, there will be in tall P wave in lead 2, whereas in V1, the initial positive deflection will be taller. When there is a left atrial enlargement, there is a bifid P wave in lead 2, whereas in a V1, the terminal negative deflection is wider and deeper, as indicated by Morris index. The more than the product, that is depth, the duration of the terminal deflection into the depth is more than 0.03 indicates left atrial enlargement. When there is a both right atrial enlargement whereas a left atrial enlargement, there will be a bifid P wave with the initial taller P wave. It is called as P tricuspidale. Whereas in V1, this both the positive and the negative deflection will be prominent. So this is a ECG showing there is a broad P wave in the lead 2. This is called as P mitral. It is due to left atrial enlargement, most commonly seen in mitral stenosis. So this is a ECG in the lead 2 showing the tall P wave that is more than 2.5 square box. That is usually due to right atrial enlargement due to pulmonary hypertension. See here we can see that inverted P waves in the both, but the difference here is the PR interval is shortened, the PR interval is normal. A normal PR interval with the inverted P waves is ectopic atrial rhythm, whereas a shorter PR interval with the inverted P waves is called as a accelerated AV junctional tachycardia. So coming to the nomenclature of the QRS complexes. So any initial negative deflection is called as a Q wave. Any positive deflection is called as a R wave. Any negative deflection after an R wave is called as an S wave. A completely negative complex is called as a QS complex. So here there will be only a there is no negative wave. This is called as only a positive wave. This is R wave. Here there is a positive wave followed by a negative wave. It is called as RS. Here there is a similarly there is a positive wave followed by a negative wave, but the R wave is smaller than the S wave. So you use the terminology small r. Here, this is the normal. This is the initial negative wave, a small q wave, followed by a large positive R wave, followed by small negative. This is called as QRS. This is a normal complexes. Here, there is an initial large negative wave, followed by a normal R wave. It is called as QR wave. Here it is initial negative wave, there is no positive wave, it is a completely negative complex, it is called as QS complex. Here is there is an initial negative wave followed by a small R wave, it is called as QR wave. Here there are no negative waves, only positive waves, that is initial positive wave is called as R, whereas there is one more positive wave, it is called as R dash, but the initial positive followed by R is called as RS. So as it is the terminal second positive wave is called taller, we use small r, S and capital R, RSR dash pattern. This is a QR pattern, this is a R only R pattern, this is R dash pattern, the initial positive, both there is no negative waves, only positive wave, there are two positive waves, but this, the negative deflection does not touches the baseline, so we cannot call it as RSR. So this is the example of fragmented QRS complexes which is seen in bundle branch blocks. So the Q waves is a septal Q wave. So this initially it depolarizes from left to right in direction. So the vector is in opposite direction. The small Q waves is normally present in lateral leads, that is 1 AVL V5 V6. What are non-pathological Q waves? It should be present in these leads, which is 2 small square deep, that is less than zero point 0.2 millivolt in depth, and less than 1 small square wide, that is less than 0.04 second, and it should be less than 25% of the amplitude of the R wave. When it is pathological, it is more than 1 mm wide, more than 2 mm depth, more than 25% of the R wave, and any Q wave seen in V1 to V3 is pathological. So what are the causes of Q waves? The most common cause of Q waves are mainly due to myocardial infarction, but you need to know the other causes also. There are physiological variants that is mainly due to the wrong placement leads or a dextrocardia or a left-sided pneumothorax, or due to altered ventricular conduction such as left bundle branch block and WP syndrome, ventricular enlargement such as LVH and corpulmonale, myocardial damage or replacement by fibrosis seen in myocardial infarction, myocarditis, cardiomyopathies such as hypertrophic cardiomyopathy, restrictive cardiomyopathy, others such as pulmonary embolism and pheochromocytoma. So these are the differential diagnosis of key waves. But what you need to differentiate is whether it is a pathological key wave mainly due to MI, or whether it is a physiological or pathological, whether it is a pathological key waves due to myocardial infarction or others. So when there will be a loss of normal Q waves, normally Q waves is seen in lateral leads. When there is a complete loss of Q waves in V5 and V6, it is seen in left bundle branch block. So what are the characteristics of the necrosis Q wave? This slide, you can read it if you want to know it further. But remember, Q waves in V1 to V3 is always pathological. A small Q waves is physiological in lateral leads. A wider and deeper and more than two-third of the one-third of the R wave is always pathological Q wave. A wider, a deeper Q waves are pathological, and Q waves in V1 to V3 are pathological. A small Q waves in lateral leads are physiological. So this is an ECG showing an ST elevation in inferior leads, lead 2, 3, AVF, and there is a prominent Q wave in lead 3, AVF, as well as lead 2, and there is a reciprocal ST depression in AVL. So this is a case of inferior wall MI. This is an evolved inferior wall MI, so you are seeing in a Q waves. So what are the abnormalities of the R waves? So there are three key R wave abnormalities, that is dominant R wave in V1, dominant R wave in AVR, and poor R wave progression. So what are the causes of dominant R wave in V1? R wave in V1 dominant, it indicates the RV dominance. So in children and young infants, the RV is predominant compared to LV. So you will get a predominant RV. Sometimes the juvenile pattern might persist. It is called as persistent of infantile pattern. Or there might be RV hypertension or RV hypertrophy due to pulmonary embolism, which causing a pulmonary hypertension, or a left to right shunt, which causes a increased blood flow to the right side, which it causes a RVH, or when there is a right bundle branch block, posterior myocardial infarction, there will be ST depression in the anterior leads and ST elevation in the posterior leads. So there will be ST depression in V1 to V3 with a tall R wave. In WPW syndrome also there will be a tall R wave and incorrect lead placement. That is V1 and V3 are replaced. So normally V3 will have a taller R wave compared to a V1, but here the V1 will be taller due to wrong placement, or as well as dextrocardia. In dextrocardia, the as the art is on the right side, the V1 will be taller. R wave in V1 will be taller, and hypertrophic cardiomyopathy due to increased muscle mass, there will be dominant R wave in V1, and there are some conditions such as dystrophy. This is important for pediatric people. So you will get a dominant R wave in muscular dystrophies, but most of them are associated with cardiomyopathies. So this is a UCG showing in a tall R wave and V1, and there is a T wave inversion in V1 to V4. This is due to RVH with RV strain pattern. So this is a ECG showing a dominant R wave in V1, but there is a ST depression in V1 and V3. If you take a posterior leads, you might get that is V7, V8, V9, you might get a ST elevation. This is a case of posterior wall MI. You can tilt this paper and see a mirror image. Can see a ST elevation in V1 to V3. That is called as mirror image. What are the other causes of dominant R wave in AVR. So in tricyclic antidepressants such as amitriptyline poisoning, the R wave will be positive in the AVR. The R wave height will be more than 3 mm, and whereas R by S ratio is more than 0.7. So there is a taller R compared to S. And dextrocardia, incorrect lead placement, and commonly elevated in R wave. See, in ventricular tachycardia, the R wave will have a positive or a negative discordance. What do you see in dextrocardia? In dextrocardia, the QRS complexes are positive in AVR. As AVR is a right-sided lead and ART is also on the right side, the AVR will become positive. Whereas the QRS complexes will be negative in the left-sided leads, that is lead 1. And there will be a marked right axis deviation as ART is on the right side and absent R wave progression in the chest leads, as the usually R wave progresses when the from V1 to V6 as the art is on the left side. Here there will be absent R wave progress. So four features, that is positive QRS complex in AVR, negative complexes in lead 1, that is left sided leads, right axis deviation, absent R wave progression. So this is a ECG show of a dextrocardia. Here the QRS complex is negative in lead 1, whereas it is a positive in AVR, and the R wave progression is poor. Poor R wave progression. Poor R wave progression is described with a R wave less than 3 mm in B3. It is caused by prior anteroseptal MI, left ventricular hypertrophy, inaccurate lead placement, and it might be also a normal variant. Next is coming to the QRS complexes. So in QRS complex, you need to concentrate on three things, whether it is the width of the complex, whether it is a narrow or a broad, and the voltage of the complex, and any specific morphology of the QRS complex. So what is the normal QRS width? So normal QRS width is 70 to 100 milliseconds, but sometimes up to 110 milliseconds it is acceptable in healthy subjects. A normal QRS complex indicates it is supraventricular origin. So supraventricular origin means it can arise from three places. That is sinoatrial node, that is a normal P wave, or a atrial, that will be abnormal P wave, and AV junction, P wave might be absent or hidden. In AV junctional tachycardia, the PR interval will be shortened. So these are the differential diagnosis of narrow complexes. When there is a broad complexes, it might be due to ventricular origin or an aberrant conduction of supraventricular complexes. That is, there will be a what are the a duration QRS duration of the 120 milliseconds favors diagnosis of wide complexes. It might be due to ventricular rhythm or supraventricular with aberrancy. What are the causes of aberrant conductions or bundle branch block, right bundle or left bundle branch blocks? Hyperkalemia, tricyclic antidepressants, WP syndrome, ventricular pacing, hypothermia, and intermittent aberrancy, that is due to rate related aberrancy. So this is an ECG showing in a tachycardia is there. Okay, so that is around 150 is there. So the complexus is narrow. So it is a narrow complex tachycardia. Now we need to observe for the morphology of the P waves. So this is the flutter waves. So it is called as atrial flutter. Here the QRS there is a tachycardia, but QRS complex are broader. So it is probably a ventricular tachycardia. Next is voltage. In voltage, high voltage QRS complexes are seen in left ventricular hypertrophy. That is the commonest used criteria is Sokolov-Lyon criteria. That is S wave in V1 and tall R wave in V5 or V6 more than 35 mm. Next is low voltage QRS. That is in chest leads, chest leads it should be less than 5 mm, and in in limb leads it should be less than 5 mm, and in chest leads it should be less than 10 mm. It is seen in hypothyroidism, pericardial effusion, and thick chest wall. Electrical alterance, that is QRS complexes alternate in height. So that is alternating QRS voltage, that is due to art swinging back and forth within a large fluid. Electrical alternance. QRS complexes alternate in height. It is seen in massive pericardial effusion. Alternating QRS voltage is due to the art swinging back and forth within the large fluid-filled pericardium. So, what are the distinctive QRS morphologies? In Brugada syndrome, there will be RBBB with ST elevation in the anterior leads, that is V1 and V2. In Wolff-Parkinson-White syndrome, it is due to the pre-excitation, there is a delta wave seen, and in tricyclide poisoning, the QRS complex will be wide with dominant R wave in AVR. So this is a Brugada sign. You see a ST elevation with the RBBB in V1, V2. It is diagnostic of Brugada syndrome. Now, next coming to the T wave. T wave is due to the ventricular repulsion. T wave is not symmetrical, it is asymmetrical. The first off have a gradual slope, then the second off. T wave corresponds to QRS complexes. So, T wave is in upright in the left-sided leads, whereas it might be inverted in the right-sided as well as inferior leads. T-wave inversion in lead V1 is also common, as V1 is also usually placed on the right side. The presence of symmetrical T waves is suggestive of myocardial ischemia. This is very important. Symmetrical T waves suggest myocardial ischemia. Asymmetrical inverted T wave inversion is a non-specific finding. So the T wave should be generally at least 1/8 to 2/3 amplitude of the corresponding R wave. T wave is usually less than 10 mm. Tall T waves, where you see tall T waves is seen in hyperacute stage of acute myocardial infarction, Prinzmetal angina, left ventricular hypertrophy. It might be a normal variant also in V2 to V4 in young males in a case of early repolarization syndrome, and also a feature of hyperkalemia. But how to differentiate all this based on the associated other ECG findings? You need to differentiate all these causes. So, when there will be a loss of precordial T wave, normally T wave is inverted in V1. If it is upright and new onset and taller than V6, it indicates a new onset myocardial infarction or a coronary heart disease. So when there will be inverted T waves, normally T wave is inverted in lead 3, and in children V1 to V3 there will be T wave inversion due to dominant RV forces, and the juvenile pattern T wave inversion might persist in young women, but it is asymmetric and shallow, and in acute coronary syndrome in acute coronary syndrome, T wave inversion might be transient and it will be symmetric. In prior MI, there will be T wave inversion might persist, but there will be associated Q waves. In bundle branch blocks, there will be T wave inversion, but the T wave inversion will be opposite to the direction of QRS complexes. That is, in RBBB, there will be a M pattern of the R wave in V1, which is upright, followed by a T wave inversion in V1. In an LBBB, similarly, there is a broader QRS complexes, which is upright in the lateral leads, followed by a T wave inversion. In a ventricular hypertrophy, there will be associated in RVH, there will be tall R wave in right-sided leads, that is V1 and V2, with associated T wave inversion, sometimes associated ST change, that is called a strain pattern. Similarly, in LVH, there will be a tall R wave in V5 or V6 with T wave inversion with ST changes. In pulmonary embolism, it causes RV strain, that is T wave will be inverted in V1 to V3 and 2, 3 AVF, and the more specific sign is S1, Q3 and T3. That is a deep S wave in lead 1 and a Q wave in lead 3 and T wave inversion in a lead 3. This is a specific sign but least sensitive because the most common ECG sign in pulmonary embolism is sinus tachycardia. In HOCM, you see T wave inversion in all precordial leads. In raised intracranial pressure, the T wave will be very deep with bizarre morphology that is seen in is called as cerebral T wave that is seen in subarachnoid hemorrhage, CVA, and traumatic brain injury. It occurs mainly due to the altered release of catecholamines which causes subendocardial ischemia. Hypokalemia, the most common finding in hypokalemia is a flatter T wave rather than the generalized T wave inversion, and it is asymmetrical. Other transient causes such as any acute LVF, electroconvulsive therapy, stress-induced cardiomyopathy, pheochromocytoma, and RVPC. And other permanent cause of T wave inversion is arrhythmogenic right ventricular dysplasia. And there are many other non-ischemic cardiac causes of T wave inversion, such as pericarditis, myocarditis, athletic heart syndrome, cardiac metastasis, and non-cardiac causes such as post-tachycardia and hypokalemia. So, sometimes T wave might be biphasic also. In MI, it is initially up and down suggests myocardial infarction. Down and up T wave suggests hypokalemia. Flattened T wave, which is global, it is seen in hypokalemia. So this is the ECG showing. See, here the T waves goes up and then down. This is ischemia. Here the T waves goes down followed by up. This is hypokalemia. So here is a tall P wave you see in Prinzmetz angina. Also you see in hyperacute stage of acute myocardial infarction. Initially, there will be a tall T wave followed by a ST elevation, later followed by the onset of Q waves. In hyperkalemia, initially the T waves becomes tall, later there will be a loss of P waves, later the QRS complexes becomes widened. See, this is a case of ECG showing a recent MI. You see this T wave inversion. See, this limb and this limb are symmetrical. That is symmetrical like V. Asymmetrical means one limb will be like this and other limb will be smaller. So the two limbs will not be symmetrical. So this is one limb, this is second limb of the T wave. So U wave is a small positive wave following the T wave. So it is not normally seen in all patients, but it might be found in athletes. When the heart rate is decreased, you might see a physiological QVS. But it is most prominent QVS you see in hypokalemia and hypercalcemia. Why it occurs? It occurs due to repolarization of mid-myocardial cells. So mid-myocardial cells are situated between endocardium and epicardium and the Purkinje system. So this is a ECG showing a hypokalemia. T waves are a flatter ST segment depression and there is a small positive wave following T wave, that is U wave. Now, what do you mean by Wellen syndrome? Wellen syndrome, when there is a critical stenosis of LAD, there is a T wave inversion in V1 to V3 or biphasic T waves in V2 to V3. So this is called as Wellen syndrome. In type A, biphasic T waves. In type B, it is only inversion. This is a type 1 valence, and this is a type B valence. What are Osborn J waves? Osborn J waves are most commonly seen in hypothermia. So, what is a J point? You need to understand. The J point is in the ECG is the point whereas the QRS and ST segments mix. So the J point might deviate from baseline in early repolarization, MI, LVH, RBBB, or digitalis effect. What are the causes of Osborn wave? Osborn wave is characteristically seen in hypothermia, most common, but there are other causes also. such as hypercalcemia, acute MI, stress-induced cardiomyopathy, that is called as Takotsubo cardiomyopathy, LVH, normal variant, subarachnoid hemorrhage, myocarditis, Brugada syndrome, and idiopathic VF. See, this is the J point, whereas QRS complex meets with the ST segment. Okay, this is a J point elevation. The QRS with the ST, the point is elevated. This is called as J point elevation. And this is a J wave. That is a small positive wave at the J point is called as a J wave. This is a J point depression. So this is the ECG of the hypothermia. You see there is a small J wave at the J point. Now next comes to a delta wave. So what is a delta wave? A delta wave mainly seen in WPW syndrome. It is a slurred upstroke of the QRS complex due to pre-excitation of the ventricles. So ventricles get excited early. So the QRS upstroke is slurred. So the PR intervals is shortened. So the characteristic findings in WPDW syndrome are short PR interval, broad QRS complex, and a slurred upstroke to the QRS complex. That is a delta wave. Delta wave, broad QRS, and short PR. So that is the characteristic triad of WPW syndrome. So here you see in this ECG you see the QRS complex is the initial wave. This is slurred. This is called as a delta wave, and the interval, that is the PR interval, that is from the start of the PR interval, is also shortened. That is from start to start of the R wave. This is also shortened due to the pre-excitation. So short PR interval, broad QR. See, the QRS complex is broader. PR interval is shortened, and there is a delta wave. So this indicates it is WPW syndrome. Next is epsilon wave. See how you see a deflection in the ascending limb of the QRS complex. When you see a deflection at the end of the QRS complex, it is called as epsilon wave. So this is the opposite of a delta wave. This is caused by post-excitation of the myocytes in RV. So this is the characteristic findings in ARVD. See, there you see in ascending limb. Here you see at the end of descending limb of the QRS complex. This is a epsilon wave. Epsilon waves mainly are seen in ARVD, but it can be seen in posterior MI, RV infarction, infiltrative disease, sarcoidosis. Mainly when there is RV involvement and RV ischemia is there. So you can see a epsilon waves. In subsequent chapters, I will speak about in chapter 2 leads, axis, rate, and rhythm. There I will explain why some leads are positive or some leads are negatives, and the placement of leads and approach to arrhythmias. And in chapter 3, I will speak about intervals, that is segments and intervals, that is PR segment, PR interval, ST segment, and QT intervals. So thank you. Keep